All right. Thank you for joining us online, everyone. This is the One Health Academy monthly discussion series, and this is Blair Budd. I just want to take a moment out for those in the room and also online to acknowledge those that have made it possible for us to be here. So I want to say thank you to ASM for hosting us here in the room each month. They are wonderful, and they have some resources for us in the back of the room for those of you who are here. So please take advantage of that. And also want to say thank you to the One Health Commission for allowing us webinar access. And please consider supporting them if at all possible. There's some information on that for the webinar for those of you that can attend with us remotely. It wouldn't be possible without the One Health Commission. So thank you so much. And without further ado, tonight's main event, Dr. Joseph Annelli is a former USDA Animal and Plant Health Inspection Service Veterinary Service Senior Advisor for Agriculture and Health System, One Health Coordinator, and Director of the One Health Coordination Center. He retired this past January after a 32-year career covering a broad range of policy and program development to start his own consulting company, Practical One Health Solutions. A native of New York, Dr. Annelli received a BS in biology in 1976 from St. Francis College in Brooklyn, New York, and an MS in zoology with an emphasis on oceanography and wildlife management from the CW Post campus of Long Island University. He received his Doctor of Veterinary Medicine at De La Salle Araneta University in Quezon City, Philippines in 1983 after completing his senior year of clinical practice at the University of Tennessee College of Veterinary Medicine. Throughout his 32-year federal career, he was and still is an innovative thinker. He's managed USDA's engagement in the White House's Avian and Pandemic Influenza Preparedness Implementation Plan, while on detail to the USDA Secretary Office, leading the USDA International Avian and Pandemic Influenza Response Team, developing a crisis management center at the Food and Agriculture Organization in Rome, leading USDA on global health security at the White House, initiating the USDA-wide One Health Joint Working Group, the Federal Interagency One Health Working Group, and finally founding and leading the USDA One Health Coordination Center. Wow. Today, Dr. Annelli continues to advance the cause of One Health. Post-retirement, he has started a consulting business called Practical One Health Solutions and has been consulting with the World Health Organization on the development of a zoonotic disease guide. Please join me in welcoming Dr. Joseph Annelli.
Thank you. Thank you. I can't wait to hear what this speaker is going to have to say. So let's get into it right away.
Just the arrow button.
Okay. Oh. Okay. When I was asked to speak, I was thinking about what else could be said about One Health. I mean, it hasn't already been said. So I started looking for some things that are really the critical way forward for us. And I thought one way I might get people interested is to pose the question, does One Health have a future? I mean, we've been talking about this for a while. What is the future of One Health? And the challenge is not the technology and scientific approach, but it's this human condition of competition, compromise, and partnerships. So I thought we should look not at the technical aspects of One Health and whether this is good or not, but why isn't it possible that we're not further along? I was at a meeting a couple of months ago where they put together a scenario to look at what global health security would be in 2040. And in the scenario, they said there was an avian influenza outbreak in Southeast Asia, and because of One Health and it having been fully implemented, that outbreak was able to be contained within 2 years. After I stopped laughing, I said, excuse me, but I think your scenario may be a little bit unrealistic, that One Health will not be fully implemented in 2 years. But anyway, this is also what got me thinking about this as to why aren't we further along? So the future of One Health really starts in the past. And I know a lot of you know this, so bear with me to just go through this. It'll just take a few seconds. Aristotle in 384 BCE wrote about human and animal anatomy and comparisons. So a lot of people quote Aristotle as actually beginning this One Health effort back then. Well, then you move a little bit forward into the 1850s and you talk about Rudolf Virchow, who coined the term zoonoses. So this was that first link between human and animal diseases. And then you move a little bit forward, James Steele, as a veterinarian, in 1947, founded the Veterinary Public Health Division at CDC. I think that's a really landmark statement that the human health organization would bring in a veterinarian, number one, and particularly in the 1940s, and create their own division of veterinary public health. Calvin Schwabe, in some of his books, in 1964, coined a term, one medicine, which is essentially synonymous with what we call today One Health. So a lot of people credit him for this One Health evolution. But those are pretty sort of past history kinds of things. Let's look at a more modern era of One Health. So for me, at least, in Hong Kong in 1997, there were some sick birds in live bird markets throughout Hong Kong. And that ordinarily would not have raised any concerns. In fact, in 1985, I was dealing with the same kind of birds dying in live bird market systems throughout New York City. We never worried about this. This was a bird disease. People didn't get avian influenza back then. But in 1997, there were some children that died. These children were living in and intimately associated with these chickens that were also dying. So people started to notice that there was maybe some unique emergence here, that this avian influenza strain is now beginning to affect people. It sort of went away. I don't know whether that was a reporting bias or what, but we didn't hear much about it until around 2004, when China, Indonesia, Japan, Thailand, Vietnam, and South Korea all experienced outbreaks of these sick birds and people getting sick and dying, and they were in association with these birds. So all of a sudden, the world started to look at this going, the sky is falling. Sorry, a little chicken little sort of thing. Okay, so one of the things that I was at meetings at the State Department and elsewhere, looking at me going, well, you're the director of emergency programs for USDA. What are you going to do about this? I'm like, do about it? One, we barely have enough money if this outbreak was in New York to deal with it. What about all these countries? So there was a sort of groundswell of interest to actually do something about this. And it culminated in about 2006 into the U.S. National Strategy for Avian and Pandemic Influenza. And this document has 326 specific tasks. I know because I had to record them for USDA, 326. And the way it was written is it not only said what needed to be done, but it said when it needed to be done, and also who was going to do it. USDA, USAID, Health and Human Services will work together on this particular activity. So in some ways, this was really the beginning of this multi-sectoral collaboration, defining who would do what and saying that they would work together. Saying being the operative word. Then we go a little bit further forward, and there was an avian and pandemic influenza ministerial meeting in India in 2007. And I'm sorry for the people in the room, but I knew that this presentation was going to be posted online and that the webinar, I put more text in here to actually communicate this information better than just giving you an outline and speaking to it. So if you can't see it, for those on the webinar, the first 2 rows are essentially empty. Everyone else is sitting in the back, so if you can't see, there's plenty of seats. Anyway, at this ministerial meeting, it was the first time they used the word One Health. And one of the things that was put in the conference report was that promoting One Health could be the natural extension of the global response to avian influenza. And for me, being directly involved in that, that's really where One Health started to blossom in the world community. These ministerial meetings, for the first time, had ministers of health and ministers of agriculture meeting together to discuss a common problem. And many of the ministers of health had no idea that people could get these sorts of diseases from birds and so on. So it was a real eye-opener that the Department of Agriculture did anything with disease, no less something that was transmissible to humans. So we went from Aristotle to today. That's 2,403 years that we've been dealing with One Health. So where are we today? One would think 2,403 years might be enough to actually do something. So if we only look at this modern era of One Health, Bill Lyerly's lifespan perhaps, no, 12 years, okay? From that 1997 piece to today is only 12 years. These things take generational changes, which is 20 years. So let's see where we are. Who here thinks that One Health is a good idea? Show of hands, please. I was a high school teacher, so there'll be a quiz. All right, everybody here thinks it's a good idea. I wonder how many people on the webinar raised their hands. Second question, is it a way to better use skills and infrastructure? Everybody, who thinks? Yeah, okay, good. Is it more economical than not using this collaborative approach? What do you think? Yeah, right? And so therefore, it's a good idea. Everybody here agrees, right? It must be fully implemented among all ministries, agencies, NGOs, and private sector, right? We're done. We can leave now. Okay, so why not? Why isn't it further along? 2,400 years, everybody agrees it's a good idea. Well, at least in Western culture. And as you heard from the bio, I went to veterinary school in the Philippines, so I know it's not just Western culture. There's this concept that winning is more acceptable than losing. That competition is more prevalent than cooperation. And this is from some management books. This is about businesses. This is not about trying to get people from completely different ministerial government organizations to work together. This is about people in the same organization trying to work together, presumably with the same goals and everything. So where they're talking about this in terms of management skills, it talks about this, this competition creates conflict in intra-groups. So groups within the same organization that are supposed to work together. And we're here saying One Health is all these different groups who may have never worked together need to come together and start cooperating. Ooh, bad word. So group meetings are often conducted in a win-lose climate. We discuss an issue and you're fighting to get more money for your little part of this, and you're fighting to get more money for this little part of this, and it ends up being a win-lose climate rather than achieving some sort of mutual problem solving that says, well, you've got a little piece of this and I've got a little piece of this, and if we put them together, okay. So I put in some references to all of this stuff from the management materials that I found. One of the things that many of us that were working early on in this One Health arena said was that we need to just get everybody together globally and begin talking about where we need to collaborate. What are the essential things that need to happen to get this One Health concept to move from concept to implementation? So again, a lot of words, but let me talk through them. This was done in close collaboration with the World Health Organization, the Food and Agriculture Organization, and the World Organization for Animal Health. I think I may have said the first one wrong. So it truly was that cross-collaborative kind of approach there. The U.S. Centers for Disease Control and Prevention hosted this meeting in Stone Mountain, And again, it was called A Policy Perspective, Taking Stock and Shaping an Implementation Roadmap. The specific goal of that Stone Mountain meeting was to identify clear and concrete actions to move the concept of One Health from vision to implementation. There were 6 specific things that came out of that meeting. And we all left that meeting thinking that if we could, within the next 3 to 5 years, work on those 6 areas and developed the base of knowledge necessary to go forward with One Health, it would be like pushing this boulder over the mountain, and it would just cascade down the other side of the hill. So what were some of the assumptions? What were some of the incorrect assumptions we made when we said that? Well, we thought that if you could demonstrate that there were advantages to doing One Health, everyone would just do it. I'm sure there's a copyright infringement there somewhere, but yeah, everyone would just do it. And this was the logo from that Stone Mountain meeting. The 6 items that were brought up was that there needed to be a business plan work group. There needed to be a capacity building work group, a country level needs assessment work group, a One Health global network, a proof of concept work group, and a training work group. So these were the critical elements of One Health from 8 years ago. Anybody familiar with the Myers-Briggs personality type? Okay. So that thinking is INTP thinking. I am an INTP. 3% of the population are INTPs. What this says is, if I just had an opportunity to explain it to you, you would understand why it's the right thing to do, and you would just go do it. I forgot there were 15 other Myers-Briggs types that I was talking to. So that maybe wasn't the best way to approach it. I put that in there because at my age, I forget what those INTP things stand for. So where did we get with these 6 things? Well, the business plan group kind of worked for a while, but there really was no outcome from them, because if we're doing this worldwide, how do you establish a single business plan for every country, every ministry? It just wouldn't work that way. They did do some work in like cost effectiveness of using One Health, but there wasn't a lot of data out there, so they didn't go very far. The capacity building work group has been moved on into the USAID program for emerging and re-emerging infectious diseases as a capacity building project. So I think it's the University of Minnesota, maybe Tufts. I'm sorry if I'm forgetting some of the other people, but you can go look this up, that are involved in developing capacity in 32 countries that were picked for the global health security agenda that the US would help support. And they're working with universities to develop a future One Health workforce. This country level needs assessment evolved into a couple of different things. One of the ones that I was directly involved in the University of Minnesota was the One Health systems mapping, One Health systems mapping assessment resource tool. Yeah, sorry, it's been a while since I thought about those. And I'll give you a reference for that later. It's on the University of Minnesota website to look it up. The Global Health Security Agenda used needs assessments to identify where in all of their levels that people are. And then there was a joint external evaluation program that was done with WHO, where there would be a team that would go into a country and review their goals on the National Action Plan for Global Health Security. So these are really where these needs assessments have moved into. Then the One Health Global Network, that was kind of started, but it really wasn't maintained. In fact, it's still out there, but there wasn't the funding to keep this up. So now the One Health platform has really taken over some of that, the global network, and also the One Health Commission has taken a lead with their website and all the materials they put out, has taken over this role of the global One Health network, and it's a great one-stop shop to hear things about One Health. The next one was this proof of concept work group, and they did produce papers. They did some meta-analyses and looked at the difference between solving problems within this collaborative approach versus not using a collaborative approach, and have demonstrated on an economic model that truly working together works. And then the training group, that's another one I was directly involved in. We developed core competencies for One Health practitioners. We felt that if we had a definition for what it was to work in One Health, it would give you a sense of, okay, here's what I want to do with my career, and you make sure that you meet the certain competencies. The interesting thing about this is it makes the assumption that you come into this with a technical skill. You're a microbiologist, you're an epidemiologist, you're whatever you are, and on top of that, you need to have these core competencies, which are collaborative thinking, working together, building partnerships, all of those kind of soft skills you need to be able to put the technical stuff together and make it work. So, was it a lost cause from the beginning to try and start this? 2,400 years, lost cause? Or has this actually got some glimmer of hope to make it past its 20th birthday? Well, I'm sorry to say that in some of the research I did, it doesn't look very promising. There is this basic incompatibility between authority and structures of organizations and human personality. You know, how many folks here like being told what to do? That's what our organizational structures say, right? You will do this, you will do it this way. You may have a better idea, but you're not being allowed to profess that better idea and have it work. The second bullet here is human behavior cannot be separated from the culture that surrounds it. So even you, folks that are still working, are within an organization that gives you a culture of not participating in this One Health thing. Why? Well, we've always been really good. We're the best in the world. We don't need anybody else to help us do this. So we'll just hire some new expertise when a new issue comes along. We will not reach out and get somebody who spent 30 years of their career working on avian influenza. We will simply call over there and say, hey, we're about to go to country X. Can one of our folks come over and spend a couple hours with you and learn about avian influenza? So that's kind of the way it goes. But the system we're in forces us to do that. Congress said agency X gets X amount of money to do this. Congress did not say agency X gets to give that money away to other agencies because other agencies might be better equipped to do that job. That's not allowed. So again, this stuff comes not from epidemiology. This stuff comes from basic business management books. So why is it so hard to work together? I found this stuff very interesting. There's a book called Reinventing Organizations. It was originally written in French. I don't speak French. I got the English copy. What he said was that we only demonstrate 1/16 of our personalities. That the other 15/16 we keep hidden. We hide behind this mask because we're afraid other people will judge us, that we'll be criticized for saying what might be on our mind, no matter how crazy an idea that was. I know I've worked with some of you. You were not afraid to raise crazy ideas, and we usually worked with them. So maintaining this mask takes a lot of energy to begin with. And then working together requires even more energy. So you've got this mask that's taking a lot of energy away. And on the other hand, then to properly partner with other groups takes a lot more work than if you just went and did it yourself. So therefore, you're not likely to do it because you're exhausted and it doesn't really pay right away. And the last item here is This effort isn't always immediately rewarded. In fact, I've often said no good deed goes unpunished. So even though you're trying to push the edges of the envelope, you're not being rewarded for it, even though it's the right way to go. In fact, oftentimes you're being criticized for doing that, not staying within your lane, so to speak. So, how much more support do you need? Here's a letter from Barack Obama directly to the Secretary of Agriculture. He's talking about the antimicrobial resistance activities of the USDA. And right there at the bottom, it's small letters, toward that end, I urge you to continue your focus and particularly attention to work across the United States government to fully incorporate a One Health approach inclusive of human, animal, and environmental health to ensure we are doing all we can to respond to this threat to global health security. The President of the United States directly telling the Secretary of Agriculture, do this. Similar letters went to the Secretary of Health and Human Services, went to the Administrator of EPA, and so on. So, done, right? President says it. Well, you need to walk that talk. You need someone in leadership who can write the check, commit the resources, and execute consequence management. That's the way you make change. Write the check, commit the resources, execute consequence management. What's wrong with this letter? This letter supports it, except it didn't give the Department of Agriculture a check, nor did it give it the resources it needed, and there was no follow-up to fix it if nothing was done based on this letter. So nothing happened. Congress gave money to Health and Human Services to do antimicrobial resistance work, despite this letter saying the Department of Agriculture should. The Department of Agriculture didn't get any money. So as people are talking about the risks from farms creating antimicrobial resistant organisms, we really don't have enough data to prove that in any way. And it continues today where there's inadequate funding on the agricultural side. I'm kind of tired of trying to balance myself on this one, maybe 1.5-legged stool of One Health. We need to kind of get all the legs of that stool hitting the ground. Now, I've been criticized for this many times because I like quoting Machiavelli. And, you know, there's a whole bunch of issues about Machiavelli and you know, how tyrannical his ideas were and so on. But I've had this saying up over my desk for quite a long time, since emergency program staff. This is what Machiavelli said, and this is back in the 1500s. It must be considered that there is nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. That's what we're doing with One Health. It's a new order of things. For the reformer has enemies in all those who profit by the old order, and only lukewarm defenders in all those who would profit by the new order. This lukewarmness arises partially from the incredulity of mankind, who does not truly believe in anything new until they actually have experienced it. So, does One Health have a future? Did I paint too bleak a picture here? All right. Yes, most definitely One Health has a future. In fact, I would say that the human race may not survive without it. Let that sink in. The human race may not survive without it. Look at all the emerging infectious diseases. Look at the complexities of our systems. If we don't work together, we are not going to be able to overcome nature's changes and get ahead of these things. We do need to continue to breathe life into One Health. We're at a tipping point. One Health will either fall apart and disappear and be a footnote in future textbooks, or 30 years from now, it will show up as a new idea in somebody else's textbook. But we are at that tipping point where it's either going to disappear or it's going to be on a glide path to actually being incorporated. And I like to think that we're heading over that hill into that glide path. But the number one charge that we have from today forward, that this second decade of One Health engagement needs to include physicians. Thank you, Dan, for being here. But if I tried doing a simple Google search, and everything around One Health, with the exception of this one article that's down at the bottom here by Dr. Barbara Horowitz, was veterinarians talking about the value of One Health. It was not physicians reaching out to say, we need to do more about this. I was very pleased when I went with my grandson, who was, I guess, 6 months old at the time, to his pediatrician's visit. And the pediatrician actually asked about any pets in the house and started to look at those other sorts of things that most people, I mean, maybe as a pediatrician, they're probably closer to veterinarians than most other physicians. But still, the one thing that needs to keep pushing this over that tipping point is to create an educational environment in which physicians understand and recognize the value of this collaborative work. This paper has a lot of things about what medical schools need to do to include this. And just recently I read an article that Harvard Medical School is now offering a sort of a veterinary component. They're using the Zubiquity book as the basis for that. My opinion is that the wonderful person who wrote the Zubiquity book had an amazing grasp of the obvious, because every veterinarian was looking at that going, you were surprised? What? But these things in medical schools need to happen to broaden their perspectives. In fact, when I was in graduate school too long ago to mention, Mike Osterholm came in to speak to our public health class, and he said he preferred hiring veterinarians than physicians, because the veterinarians have a broader kind of community awareness of diseases. Instead of a single person, it's herd dynamics kind of things. So, you know, it's been recognized for a long time. The other thing too is developing programs and educational opportunities that are tailored for physicians are crucial to this development. And that's what this article talks about. And I thought that was really great. From day one, when the precursor to the One Health Commission was started, that was when AVMA started an exploratory committee to look at One Health, the AMA was partnering. And they did partner for a couple of years, but have since just sort of drifted away. And that's where that tipping point is. It's easy enough for lots of others to just drift away and not stay engaged. So we need to stay on top of that. So I subtitled this, The Human Condition of Competition, Compromise, and Partnership. And let me talk about each of those. We'll talk about competition first. The time for convincing people that One Health is imperative is over. Just trying to go out there and educate people that this is a good way to do things is not going to cut it anymore. They either know it now or they don't. Going forward, we must embrace change management principles, not the technical stuff, the soft skill stuff of change management. We have to make it more painful for people to continue the way they did the old things than to change and get engaged in the One Health concept. So it's pain to stay the way you are versus the benefits that we, at least in this room and probably everyone on the webinar, would say about One Health being a better way to go forward. We also need to embrace One Health ourselves. We need to engage the other groups that are more important than our technical specialties. We need to engage, and I had just anthropologists in here, but just because of this networking and a conversation I had, I included sociologists in this. It is the sociologists that are going to help us understand how to change human behavior. Changing the technology of working in a One Health partnership is not a new test. It's making people work together. Simple as that. So we need to look no further than this Harvard Business Review that I found that says you can take the person out of the Stone Age, but you can't take the Stone Age out of the person. We still operate in our fight or flight mentality. We go into a meeting room to collaborate, and we are all thinking about, what am I going to lose in this discussion? How do I, am I going to run away from this because it looks like it's going to steamroll over me? Or am I going to stay there and fight for my position? In fact, going back to the avian and pandemic influenza thing, where it was laid out very clearly who would work together. First proposal on that, somebody said, well, let's just call this the Lanes document. So HHS will just write about what they did. And then USDA will just write about what they did. And USAID will write about what they did. Then we'll put them on one piece of paper and send it in and say, look, we collaborated. No. So that sort of human mentality of, I'm the only one who can do it. And if I'm not doing it, it can't be done right. Therefore, this collaboration that we call One Health is not going to stand a chance to work. All right, let's keep going and talking about this competition. We need to start looking at tools that we can use. Tools that are a little different than what we've done before. And we need to recognize that we're not the only ones in this One Health arena who've had this problem. This, this antidote for competition is called trust. If we trust each other, we are more likely to stop competing with each other. I'm not trying to take your favorite toy away. I'm trying to bring my toy and have them play together. And together they'll be better than they were separately. So a group came together and wrote this document called Building Trust in Diverse Teams, the Toolkit for Emergency Response. This had nothing to do with One Health. This had to do with, during a disaster, the tsunami in Indonesia, how do we bring together all of the different cultures down to the tribe level in Indonesia, to the Australian central government, to the US central government, sending people to help. So this was a collaborative effort of 7 different agencies that are looking at emergency capacity. They are jointly addressing issues of staff capacity, accountability, impact measurements, risk reduction, all of the same kinds of things we talk about in One Health when we talk about maybe infectious diseases, AMR. But in this case, they're talking about emergency response. We can learn a lot from using this document to assess our One Health diverse teams and build trust within them. The goal of this is to improve the speed, quality, and effectiveness of humanitarian communities to save lives. Isn't that what we're doing? With One Health, we are trying to bring these groups together to save lives. There's a web address at the bottom of this that you can get to this book. And what I like about this book is that it is not just a textbook. It is an actual workbook that has you put in assessment data on your own, and then you compare those with others to see who is risk averse, what are the team factors that have you collaborate, what are the risk factors that you're not going to collaborate. So it's a workbook. The workbook also has a CD in it. I don't sell these, by the way. This is not a sales pitch for me. But this has everything you need, including the PowerPoint slides to lead a group through this to build these partnerships. So next time you have a One Health meeting, and maybe with Blair, I would propose maybe we try this in this group one time and see how that goes, to see if somehow we can address this trust issue among ourselves. Anyway, let me move to the next slide. I think I'm running a little bit slow. So, compromise. We have an excellent example just a mile down the street of compromise, or lack thereof. I love not working for the federal government anymore. I can say that. So there was an article in Forbes about Congress and the lost art of compromise. So everyone is expecting that Congress should compromise. I mean, that's how you come to good decisions. You meet in the middle about the various issues that you've got and come up with the best solution. There's another paper, The 7 Steps to Compromising Effectively as a Business Leader. Great stuff. Last one. Former FBI hostage negotiator explains why compromise is a bad deal in life and in business. He says you compromise, people die. He says compromise is bad. Never compromise. If you compromise, you're obviously losing something. He gives an example. He says this guy and his wife argued over the color of the shoes he was going to wear. She wanted him to wear black shoes. He wanted to wear the brown shoes. So they compromised. He wore one brown shoe and one black shoe. Worst of all possible solutions. But it was a compromise. So I guess with this, I just wanted to warn you that while in One Health we talk about making compromises, compromises may not always be the best solution. So we need to be careful. Let's not just get lulled into this sense that, well, what we're doing here is the best way we can with One Health. Maybe not everything has a One Health solution. Maybe there are some things you don't solve in a multi-sectoral way. How am I doing on time? Okay, so I'll give you a little story. When we were looking at, we meaning the U.S. Department of Agriculture, were looking at this One Health thing, Dr. Beth Lautner, who's a member of that AVMA committee to look at One Health, and I traveled to England. And we spoke to the people within the public health department, and we spoke to the people in DEFRA. We went to the public health folks and said, so if there is a foodborne illness, how do you handle that? They said, well, we work with the people and help them with the illness and the tracebacks and so on. And then we give that data to DEFRA, and DEFRA then does the on-farm investigation, identifies maybe a point source, and then, we'll depopulate the herd or whatever needs to be done there. And we sort of nodded our heads and said, oh, okay, I understand. And then we went over to DEFRA. We wanted to find out what their side of the story was. We sat down and said, so we have a, said, well, the public health folks will call us and tell us where the situation is, and we'll help them and investigate it. And if we find that there's an animal source, we'll intervene. And it was the same story. And Beth and I both kind of took a step back and looked and said, well, aren't there jurisdictional issues here between what you can do and what? No. Well, what about funding? I mean, if they have more money than you do, are you still going to do this investigation? Well, it all comes out of the same pot. Yeah. I mean, ultimately, we were shocked that they worked together like that. Then it occurred to me, foot and mouth disease outbreak, 2001. There is no longer a, I'm losing the name. Help me. Before DEFRA, what was all right, anyway, what it took was that they abolished an entire Department of Agriculture and created this new organization with new mission. And those missions were then totally aligned with public health. It no longer mattered whether you were in the Department of Agriculture or the public health department. You had the same goals. But it took abolishing a federal department to make that happen. So let's look at this idea of partnerships. Yeah. So how do we have successful partnerships? When the partners neither see themselves as equals, nor are they equal. So let's look at least my experience with the US government and Health and Human Services and the Department of Agriculture. They do not see themselves as equals. because the human health people are kind of up here saying, well, we deal with humans. You only deal with animals. Yes, we only deal with animals, which are the basic nutrition source for most of the world. You wouldn't have people to treat if we didn't provide food for them. So there's this, and in many of the third world countries that we are working in on some of these things, the veterinary profession doesn't even have a licensing program or anything like that to validate skill sets. So there is, for example, in Indonesia, there was absolutely no involvement of the veterinarians initially because they don't even have an organization there. So let me go through this. A couple of examples where these two are not equal and are not perceived as equal is Ebola. Ebola, there was a lot of money put together to help fight Ebola. In fact, the only thing that kept the global health security agenda alive was this influx of money to deal with Ebola. And a portion of that Ebola money was set aside to deal with global health security agenda and to look at the One Health concept. Well, what's wrong with this Ebola thing? Where's Ebola come from? Anybody know? Bats? Bats, maybe? Anybody heard of bats transmitting Ebola? Maybe some other things, some deer and so on. But it comes from an animal source. So when it came to dealing with Ebola, all of the money went to treating human cases. None of the money went to an animal health unit to look at the source of Ebola, nor did we certainly look at a sociologist to tell us why people are eating bushmeat that may transmit Ebola, what is going on there. So that was not a really good example. In fact, I was sitting in a meeting at the White House the day that Liberia declared itself free of Ebola. And somebody in our group, Bill, you may have been in the room at the time, somebody in the group said, you know, Liberia is now free of Ebola. And everybody in the room sort of applauded and clapped, and except me. I raised my hand. I was the only veterinarian in the room. And they're like, what, Joe, again? I said, Liberia is not free of Ebola. Liberia has no known human cases of Ebola, but there is Ebola in Liberia. And they're like, bummer, okay. So antimicrobial resistance, another one. We put together this wonderful plan called CARB, where all of the federal government was going to work together on antimicrobial resistance. Yay, it was a wonderful document. It was a One Health document. We were all going to do these various things. Then Congress got in the act and gave all the money to Health and Human Services and nothing to the Department of Agriculture. Literally nothing to the Department of Agriculture. Remember that letter signed by Barack Obama and saying, do this in a One Health approach? How do you do that if you don't have any money or people that you can commit to it? So all the money is sitting over there in Health and Human Services, and they're doing a lot of things, and they're doing a lot of good work. I'm not criticizing them. I'm just saying that there is at least a third of the activities of antimicrobial resistance that are not being covered because agriculture is always the afterthought. Except, of course, when it's somebody looking to get money who starts blaming agriculture as the source of all evil, and it's where these resistant bacteria come from, and we need to, you know, I don't know, kill all the pigs or kill all the whatever to get rid of these organisms. Anyway, an example of a very positive approach was influenza. So Nancy Cox at CDC looked at the influenza issue in 2009. It was an H1N1 influenza. Anybody remember what that was called?
They called it swine flu.
Yeah, wrong. No, they don't. They did call it swine flu. What a disaster. Countries started banning the shipment of pigs out of the United States. So there was no understanding that simply giving it that moniker, because H1N1 is pretty common in pigs, but giving it that moniker had implications far beyond just newspapers having some catchy phrase to say you have swine flu. So what Nancy Cox wanted to know is how are these viruses evolving in its host species? So she wanted to start getting samples of influenzas from swine. And by looking at those, she would hopefully be able to find some pattern of mutation that made it more virulent or made it more transmissible to people. She just wanted a data set to analyze to see what was going on in the animal population. But she also knew that CDC didn't have a relationship with the swine industry, maybe a rudimentary one. Who's on swine farms? USDA. We ran the pseudorabies eradication program. We had people on every farm in this country at some point in the last 10 years. So she reached out to the Department of Agriculture and said, look, you have the network to get to swine farms and collect samples of influenza from pigs to send to our lab. We don't want to know names. We don't want to know locations. Separate that entirely. Just send us the viral samples so that we can analyze them and put them into a phylogenetic tree. And we want to see what's going on. So she brought forward this perfect One Health collaboration where CDC gave us $1 million or more to run this program, to be collecting these samples. And it was even our own lab, National Veterinary Services Lab, that was testing these samples. So the money they gave us was to provide the equipment to collect the samples, to ship the samples, to test the samples. And it worked beautifully. Mostly. I'm serious, it worked very beautifully. One little problem in this whole thing is called the Economy Act. There is something that Congress passed called the Economy Act. What it says is that no federal agency can supplement the appropriation of another federal agency. So CDC could give the Department of Agriculture without being reimbursed. So CDC gave us the money, but the money had to be on expenditures like mailing samples, buying media, buying swabs, and paying for the testing equipment. We were overwhelmed with samples, but we could not hire an additional person to run those samples because this Economy Act prevented it, because hiring an employee, even on a temporary basis, would have been considered supplementing the appropriation of another committee, of another agency, and we couldn't do it. So the concept was great, but we have some fundamental issues in collaboration that probably when they wrote that act, they never thought that this is, some way that it could interfere. Anyway, let's move on to these partnerships. This is again, the reference on the bottom is about these 7, I think it's 7, things you need to have successful partnerships. You have to have a successful history of working together. You have to agree on a vision. You have the hard talk about money. What we don't have, what you have, and how we need to work that out. On the previous one about the vision, for a long time, there were folks at CDC who figured anyone in the Department of Agriculture was only interested in animal health and trade and at the expense of human health. So it took a while to get over that preconceived notion to say, no, we care about human health. In fact, USDA is a public health agency, but we also balance that with trade considerations and all of these other things. So we have a much more complex view of how this works. You have to decide who the real leader is. Isn't that a nasty discussion? 6 of you from different agencies sitting around the room deciding who the leader is. Well, from your home agency, better be you, right? So how do you actually work that? You need to ensure that you understand each other's commitment. Let's talk about that influenza virus samples in swine. Who does that help? People. Who is putting out the expense and the work to collect those samples? The animal industries. So the person doing the work is not receiving the benefit of the results. How is that sustainable? So obviously USDA wouldn't have much commitment to continue this. When times get hard and money gets short, that could very well be the first thing that gets cut off, because it's not really within the purview of agriculture to look at swine influenzas. That's something that's managed between the private veterinarian and the herd owner. Have compatible and vital skills. Make sure that the people you're working with have the skills you need to work in this, and have compatible styles. That's been a real issue that I've seen over the years in what, say, CDC's style is, what HHS Global Health Division style is, what USDA's style is. And when I say USDA, we're like big. So FSIS style might be different than APHIS style, might be different from others. So we need to understand those. So in summary, this is my last slide. I hear yay going on. We need to add new tools to our toolboxes. And I'm not talking about the technical stuff. This OSMART tool, and here's the reference I talked about, is a way of bringing people together from different backgrounds. So this multi-sectoral group. You have the different groups write up a process that they would follow to do something, and then you have them present to the whole group. And all of a sudden, people start making connections that say, well, we had that information. If you'd called us, we could have given you that, and we could have then worked on it together, and so on. And then at the end of this process, which could take a week or maybe even months to go through this, the group comes up with the new way of behaving. Forget those organizational structures. We have a One Health structure that says, here's how we're going to report, here's how we're going to communicate, here are our common goals and objectives, and here we lay out what each of us is committing to in that partnership. The other thing we need to do is building trust. It was nice to talk about many years ago, but there is a tool that can help us in developing trust in diverse teams. And the last thing is this One Health core competencies. If we reach back to that document with all of these core competencies, which are the soft skills, and we begin to incorporate them into medical schools and veterinary schools and elsewhere, I'm thinking very narrowly with only those two, but if we can build those core competencies into one's everyday reality as a student, it's no longer a new idea when you get into the workforce. It's just the way we do things. So my final things, well, the two things here is don't overestimate the effect of synergy. If you assume One Health is the solution to everything, you're going to miss the mark. You have to watch for your own biases there and make sure you acknowledge what your bias is when you're having these partnership discussions. And the final word is be brave, be bold, and be a One Health spokesperson and advocate. Questions? Thoughts?
Thank you so much, Dr. Annelli. And just as we like to present all of our speakers here at the One Health Academy, we have a flag that was flown over the United States Capitol.
Wow.
So thank you for your time and your presentation and sharing all your One Health insights with us. So thank you so very
cool.
much.
Thank you. Thank you
really
all.
Appreciate
and
your
for
time.
all of those on the webinar, thank you. And I don't know, I've got one more selfless sort of pitch here. If you've noticed my coffee cup with the One Health Day logo on it, I found a company that produces these and will ship them directly to you. You can buy them off of my website, and any proceeds get donated to the One Health Commission.
Yay. And they are the ones that are supporting everyone on the webinar. So
yeah, great. And I'm not making any money off of them, but they're out there for you to use to give away, like the flag. Thank you.
Thank you. All right. Well, so we'll go ahead and start with questions, and I'll ask that you use the microphone so people on the webinar can hear. So go ahead.
I hate to start, and I don't want to face people with my bald face. So this is some comments and then some questions. And bear with me, I'm not going to put you on the spot. We were very lucky to have the name you mentioned, not Obama, but the secretary that we had.
Yeah, Tom Vilsack.
Yeah. We were very fortunate to have Vilsack as our leader and start the One Health program in USD. And I think no other agency has a program, or excuse me, had a program that USD had because of leadership of Vilsack. Unfortunately, that did not carry on and I can say this after retirement, after 1 year is over, my ethics hold is over. It was not, I talked to Purdue myself. It was not carried on and supported from the top. That is necessary for any federal agency to have. The university is doing a good job, like Minnesota is, Colorado is, Iowa is, and all those people. Vet schools, not medical schools, are doing a very good job. The question is, I was the author of 2 One Health MOUs, one with CDC and FSIS, one with APHIS and FSIS, in combination. The problem becomes partnership, the slide you had. And unfortunately, this is going to be written up pretty, I guess, negatively in the press very soon about the outbreak we had with the resistant salmonella in the western states. It was from roaster pigs. And people got sick. And we tried to follow up. FSIS can't go on the farm. APHIS can. CDC found human patients. They can't go on the farm. APHIS can. So we got together, and the idea was for APHIS to take the lead, to go on the farm, investigate where the outbreaks were coming, and we identified 2 farms. There's no animal ID, unfortunately, in this country. Most of the development, not the so developed boards have that. We don't. So the objection came from the pork board that we could not proceed. My question is, how do you overcome those barriers?
And I would open up the answer to these to other people in the room. But the reality is you got to go back to that, write the check, execute consequence management, commit the resources. That's not being done. A proposal that I had made for One Health to truly be effective is that when Congress allocates funds toward things that are clearly a One Health objective, that those funds go to OMB, and that OMB solicit proposals from all of the different federal agencies, EPA, FDA, FSIS, APHIS, all of those, and then the greater collaboration that one is showing through that process of submitting a proposal will be the ones that OMB funds. So there is now a common goal. There's no longer competition because we are now collaboratively competing for the same funds. So we want to write the best proposal there is of how we're going to work together and how that's going to be more effective and efficient.
But industry has to play ball too.
Well, yes, industry has to be engaged.
Or somewhere you work.
Yeah. There's also that issue that we talked about before about who the winners and losers are. So if you collect an influenza sample from a pig and it happens to be one that is mutated sufficiently to infect people, the producer is afraid that they're going to be declared the villain, that it's their herd that has this problem. They're going to be depopulated, put out of business, all this other stuff. We need to change that mindset to where that producer who participated should be complimented as a hero for having found that and should be rewarded for that as opposed to being in fear of punishment. And the only other way is to approach these things at the congressional level. I and Bernadette Dunham and some other folks worked together this past summer. The Pandemic and All Hazards Preparedness Act was being redone. And we worked with Senator Tina Smith's office to incorporate, she wanted to introduce a standalone One Health bill that, likely wouldn't get anybody's attention. So we wrote up a few sentences that would incorporate what the One Health bill would have done into the Pandemic and All Hazards Preparedness Act. And it's in there saying that agriculture and Health and Human Services should work together in these various areas. It's the only way it's going to happen is if it starts, the funding allocations need to make people walk the talk or you don't get the funds.
Catherine Gensheimer.
Yeah, hi, Catherine.
Some great points you made. And, a couple of those quotes from the past about, the Stone Age man and even just trying to change organizations. I mean, it is, we see it in our everyday life, and I'm not, we all try, but it is truly like trying to climb a mountain. But a couple of thoughts too. As far as the medical community and trying to do things with medical school curriculum and physicians, they're overwhelmed with, like the current challenge in this country is opioids. And, they don't even have much in the medical schools on, pain control or, alternative ways to handle, pain medications. Some of the medical licensing boards are getting on board and requiring some sort of, continuing medical education to ensure that maybe opioids becomes more important. But I think the bottom line is that there are just so many challenges facing us in society, and One Health, clearly by the fact that we're all here, we're clearly in support of it. But we're up against a lot of other challenges out there too, some of which may make sense, some of which may not. Compromise and building a wall or whatever may or may not be the best use of resources. But I think, I think that your talk really hit on so many of the competition, partnerships, and all. Just was really great. So
thank you. Yeah, an interesting thought. Just as you were saying that, and we don't put resources into this, but I wonder what the percentage of recurrence of opioid addiction is, and whether or not service animals, support animals, not the peacock on the airplane thing, but truly, what are going back to the sociologists, what's the underlying reason that this person has gotten into this position? And is there a One Health approach that will help support that person, whatever that may be? And maybe it's the service animal, but we need to be doing some research around those to put real data to it. Now it's just sort of holistic medicine. Bill.
So really enjoyed your talk. One of the frustrations that I had during my 43-year career was I often hear people talking, and this goes to your last point, I often hear people talk about political will. I've never seen political will as a problem. It's always political won't is the problem. And to me, the worst possible thing that we could have done to title what we do is put the word health in it, One Health. Because immediately, every other sector says, no, not my problem.
Yeah.
That's yours. And it comes down to color of money, as you were saying, line items in budgets, et cetera, et cetera. But also, I feel very strongly that also throughout my career, I've been frustrated that as a public health practitioner, I think we've become very, very lazy in that we try to find a technological fix for a problem. Build a vaccine for it, build a drug for it, put a condom on it, whatever, some technical fix. And we say, oh, we don't deal with the social issues because they're in the too hard box. And to me, that's exactly where we need to go. And as you said, you kept saying, well, not the technical issues. We don't have to worry about the technical issues. How you get individuals to work together, there has to be a common motivation. And that's not always money. But as you said with the Economy Act, I could stand here and spend the next hour giving examples of the Economy Act, how it absolutely destroyed good things that we were trying to do. But you just couldn't get there in the U.S. government. And so maybe it's not the U.S. government that does it, or any government. Maybe it's another way that has the flexibility to work with these issues. But you're spot on all your points.
Thank you.
All right, well,
I think
one more question, and then we'll.
Actually, I'm not quite sure it's a question or a comment. Being the sociologist in the room, there are a couple of things that actually I'd like to share. And one is that this use of a term, which continues on forever and ever, is this distinction between what we're calling technical skills, which are hard, and soft skills, which is what we as social scientists do. And I would ask in the room that the next time you speak of needing to study other sciences, that the social sciences not be viewed as soft.
Hmm.
It is extraordinarily difficult. Some of you probably have heard this term, it's not rocket science. How many of you heard that when it has to do with a sort of a governance question? And I often respond by saying, yes, it's more complicated than rocket science. Because rocket science you can frame, you can engineer it out. What we deal with, and I think this is why your talk was absolutely essential, and I really appreciate all of your key points. I think it's very important that both in medical schools, I've worked at Tufts Medical, and it's very important that I think in the One Health field, that you understand that this need to figure out how to collaborate is very much a conversation that's occurring in a variety of health-related sectors. So for example, the social determinants of health require the same kind of complex thinking that One Health does. In fact, they complement each other. And perhaps the way of looking at what the way forward is not in a linear fashion. We have to deal with this and this and this, but there's often what I call embeddedness. That One Health is embedded in a set of questions that need to be asked in a very different manner. That once we begin to talk about a complex set of relationships, we can no longer use the same frame that brought us to that question. So it's very much both a high, what we call ideological level, how do we frame this issue, as well as all the way down to training people that the skills of collaboration are not soft, they're essential, and that they complement the ability to look through a microscope. That it's not either or, it's how do we share what we see in the microscope with somebody who may not use a microscope. So thank you, it's not really questions.
No, that's a wonderful addition, thank you.
The answer is yes.
Well, and the whole thing about One Health is you don't know what you don't know. So you got to bring all these people together, and then you throw something like this out there, and then a gem stands up and says, but we have a way to deal with this. Let's begin to look at it this way. So wonderful.
One more final question. Thank you. Yes, surprise. So great to be back in the community here and hear you talk again. You mentioned your visit over to England with Beth and just the way they had organized. And one of the things that struck me when we were carrying out like the avian influenza game across the country and number of exercises that we did was the different structures that different states have and how that reports up to the federal government. And then we also did some projects with Canada and Mexico on the tripartite, right? You know, Canada has the Food Inspection Agency, right? So our food inspection is split among different places, right? And I remember once seeing this wonderful jagged chart over who oversees food inspection on whether it's an open-faced sandwich or a closed-faced sandwich. And I didn't know if it was supposed to be funny or not, but it was really amazing how it mattered, right? How much bread to meat there was as to which agency might have primary responsibility for that. As school lunches versus restaurants, you know, it's just very well varies. It's a very jagged line here in the U.S. And as we work with different states, and just being struck by the different organizations in those states, you know, some state animal health professionals can quarantine people to stay on the farm, others can't. Some didn't know if they could or not. That's part of what the exercise raised the questions for them. I think of looking at head cow number 4, Texas. Like, oh my goodness, everything's different in Texas, right? Yeah. You know, where you have university officials who actually have some state regulatory responsibilities. I've not seen another state. And so to me, it seems like with our federalized system, as wonderful as it is, it also might complicate some of this One Health approach, because as it works its way through, different agencies throughout in all these different states are each going to have very different pieces of this. And I'm just curious, are there certain states that you've seen kind of adopt this, you know, take it on more than others, or how do you think of like the model of like in England or in Canada where maybe some of these pieces like food inspection are not as split over different agencies? And another thing, monkeypox, right? As I recall, right, the import of the animals falls under USDA, but if the prairie dogs were pets, then they fell under CDC at the time, something like that. So there's, again, this variety of, it's all these different lanes, but they're not straight.
Yeah, so let me just explain the monkeypox comment. There was a few cases of monkeypox. I think they were in New Jersey. And CDC began to look at this very seriously because it could have very well been smallpox. And what they discovered was that there was a common source of this infection, and it was prairie dogs. But it was a unique blend of prairie dogs that were in pet stores with Gambian rats. Gambian rats, used in Africa to eliminate landmines, were actually being imported into the United States as pets. They kind of look like big hamsters kind of thing. But it's another presentation. But the challenge there was this hole that these animals fell through because they weren't on a CITES list. They weren't an endangered species. So Fish and Wildlife wasn't looking at them. They weren't pets, so CDC was looking at it. They weren't livestock, so USDA wasn't looking at them. So they were just kind of flowing in with no control at all until we discovered this. Now, the link between CDC and USDA in that investigation is that CDC would identify pet stores and USDA had authority because Gambian rats were considered exotic species. So under our Animal Welfare Act, we had to have all of them registered. So we knew the locations of every Gambian rat or every store that sold Gambian rats in the country. So we could do the follow-up in the pet stores. They could do the follow-up of the people. It was a beautiful sort of combination of things. But yeah, the major issue is that they fell through the regulatory crack nobody had ever thought about. Why would you have thought about Gambian rats as an issue? So
you designed an exercise with that scenario, no one would have believed it.
And the other thing I wanted to say about your comments on all these jagged things, one of the reasons that our food safety system is so jagged is at one time in the 30s, somebody, I don't know who the president was then, thought reorganizing the whole federal government was a good thing. And they took the food safety component and put it entirely, oh no, this was probably in the a little earlier than the 1930s. They put it entirely in USDA. Then in the 30s, there was another reorganization and they said, whoa. The people who are growing the food can't be the people who are providing food safety for the food. So we're going to take that food safety thing and we're going to put it over here in FDA because now we're going to have the Food, Drug, and Cosmetic Act and we're going to create that. But people are going to be mad. Remember Machiavelli's comment? People are going to be mad. Let's not do that much. Let's leave some of that food safety stuff in USDA and let's put some of it over in FDA. Great solution. Brown shoe, black shoe. And here we are 80 years later dealing with the consequences of that jagged process. So I'm going to give another pitch for this OSMART tool because it helps you cut through those jagged things because it says when you walk in this room, you leave your ID badges behind. You are not a member of any particular organization. You're not in some sort of structure. You are here as the people that are supposed to protect this country or wherever from getting foodborne illnesses. How should we do that? Let's create this whole new informal One Health structure that we agree that we are going to abide by. And then we'll have to, when we go home, we're going to have to somehow talk our bosses or whoever into why that's a good idea and kind of what rules we have to bend a little to make it work and this sort of thing. But that's where we need to be with One Health, where we put all that stuff behind and just solve the problem.
But a positive aspect of the brown shoe and black shoe, you have another pair at home.
Yeah, be consistent.
All right, thank you so much, everyone. Please help me thank Dr. Annelli.
Thank you.
A great discussion. I have two items to note before I let you go. The National Museum of Natural History with the outbreak exhibit, please go and see it. Dan Luce is in the back. I'm sure he'll be willing to talk about it again. But there are opportunities both for volunteers for this upcoming group for this year. So by March, please let me know if you're interested. And I also have a position description for a Latino community organizer. So wanted to flag that for any interest. Please let me know and I can get you to the right people to sign up, or you can find out for more information. And then last but not least, I know a couple of you came in late. Please come see me so we can get you signed in, and if you haven't paid, I'm your person as well. So have a great Valentine's Day, you guys, and thanks for coming in person. We couldn't do it without you. Have a great one.
Oh, good, thank you.
I know we're gonna get somebody to try to be so active, but, you know, certain positions, my phone number and emails there. So if I can be any help or whatever, I'm on the Infectious Disease Society, and we have a couple of committee.